computer and the system into Epic. We don't typically see a lot of paper strips any longer running in the rooms. At one point, you'd walk into a room and you would just see them continually coming out of the room, kind of like on CBT or one of the cardiac units, just basic telemetry, okay? So, when we see the strips, if you take a look at yours, the top line is always going to be the fetal heart rate. You can tell that by looking at the numbers and any of the words that might be on there. You should be able to read them right to left, right? So, the top one is going to be the fetal heart rate. The bottom one is going to be uterine contraction pattern. Now I know this feels a little bit out of place because we haven't started interpartal yet, but I like to get this out of the way because once you are in clinical, you're going to be seeing this a lot, and the nurses focus on this quite a bit, okay? So top is the fetal heart rate, bottom is uterine contractions. All right, so how do you read what you have in your hand? Typical, normal fetal heart rate. Anybody want to guess? 110 to 160. Well done. Is it on there? You just got it. Good. 110 to 160. Now, when you look at the monitor on the floor at the hospital, it's actually going to have a highlighted strip down the middle between 110 and 160, so we can tell better if the baby is where we want it to be. Okay? We're going to talk about everything we're talking about here in just a few minutes in much, much greater depth. Uterine contraction activity, these numbers out here are pressure, millimeters of mercury. If you look on your strip, it's going to say mmHg, millimeters of mercury, okay? That pressure we're going to talk about here in just a few minutes, but that's where the contractions get monitored. All right, so back up to the fetal heart rate strip. Every one of those little tiny boxes are 10 seconds, which means your thicker pink line is going to be a minute. So if you look on your strip, you'll see that you've got darker pink lines and then the smaller pink boxes, right? So the darker pink lines are a minute. All of the other smaller lines monitor 10 seconds. Now, if you look on the other end, because this is just a typical graph, just think of it as a graph, that's all it is. When you look on the other side, we're talking about the fetal heart rate. This is not an EKG. We're literally counting beat to beat, all right? It's not going to look like an EKG. We are not monitoring electrical activity. We are monitoring the actual heartbeat of the baby. So if we go up here, we never want to see it this low, by the way. This also goes by 10s, right? So 30, 40, 50, 60, on and on, of the fetal heart rate. The baby's fetal heart rate is, say, 120, okay? So 10 beats per second, minute, beats, time, all right? Everybody with me? Beats, time, got it? All right, so how do we monitor? We've got a couple of different options. What you're going to be seeing on the floor mostly are externals that look somewhat like this, okay? So they're going to be blue, they're going to be grayish actually. The ones we have there do not have the wires on them like you see on this mama's belly. The ones you're going to see on the floor are going to look a little bit more like these wireless ones. We do have wireless. We don't tend to use them. They're having a hard time with the Bluetooth on the floor, so they're not used very often. So you're usually just going to see these plastic, yeah. They're going to be a little bit different. One's going to monitor the uterine contraction, the pressure that's being put out by the uterus. It's a tocodynamometer. It's a toco. The other one is literally an ultrasound. So they're going to look a little bit different when you flip them over. When you're on the floor, you'll be able to see that. So one's monitoring pressure for uterine contractions. We tend to put that at the top. We need to put that at the top of the fundus. So you're going to feel, remember we talked about palpating for the top of the fundus. We talked about it postpartum. This is the time you're going to do it while mom's pregnant. You're going to palpate it, and wherever the hardest part is, on the highest part of the belly, is where you're going to put the toco. Okay? The ultrasound, we're going to kind of feel around for baby. We're going to do what we call we're going to feel around for the baby. My the baby's lying. And we're going to talk about that a little bit later. We're going to talk about fetal positioning. But quite often you can look at mom and say, where have we been finding the baby? Okay? And we're going to be able to hear the baby's heart rate when we put the other monitor on mom. So, some of the other monitors also have a maternal. The wireless has a maternal. This one's actually for twins. But this one up here on the wireless is mom. The ones you're going to see on the floor, we do not have any way to monitor mom with this. We typically monitor mom with an pulse ox. Okay? If she's on full monitoring. We also have a handheld Doppler. You've seen this before. Should look familiar. Should have seen it on other units for fetal pulses. Fetal pulses and pulses about the only thing I can think of right now. But the handheld Doppler, we use that for intermittent monitoring, which we're going to talk about here in just a few minutes. And then a fetoscope. A fetoscope is kind of an older practice. It's kind of gone out of fashion. Midwives still use it. You literally put just like a stethoscope in your ears, and then this little fetoscope down here. You'll see it on the next page, where the midwife balances her forehead on it, presses it into the abdomen, and you can typically hear the baby's heart rate after a certain age, usually about 26, 28 weeks. For the fetoscope, we just don't see them anymore. We still see them sometimes in home births and stuff, but we don't typically see them any longer. We don't use them on the floor. So again, like I was talking about, the toco goes on the top, as close as possible to the top of the fundus. And then for the fetal heart rate, for the ultrasound, we put it on the baby's back. So the best place to hear the fetal heart rate is the baby's back. So we're going to be feeling mom's belly for what we can kind of assume usually is the back. We're going to be placing it there. It's going to be the firmest, least squishy part on mom's belly over the back. Okay? If that doesn't work, we move it around to the front, put it in front. But typically you're going to see on the back. Questions so far? All right, one of the other monitoring methods that we have is for internal monitoring. We actually had these out in OB-SYN Day. I don't know if you remember. I meant to grab them today, but we can definitely pull them out at another time when we do intrapartal. Internal monitoring, we screw a little tiny transducer into the baby's scalp, and then they slide in what looks like a catheter. It looks like a straw, I think, more than anything, next to the baby's head, against the baby's head in the uterine wall, to measure the pressure that the uterus is putting out in millimeters of mercury. Okay? So we do both fetal heart and contractions with internal. So why does mom have to be dilated? ROM stands for rupture of membranes. Why does mom have to have some kind of dilation in her cervix or opening in her cervix? And why does her water have to be filled? Do you think for us to be able to internal? What's that? Yeah, because you need to get past the cervix and you need to get past the amniotic membrane, right? So mom has to be at least a little bit dilated, her water has to be broke, and we have to be able to get into the actual uterus itself. We also have to make sure we know what the presenting part is. I had a doctor one time who actually put one of the fetal scalp monitors on a baby's butt because he didn't do an ultrasound beforehand, even though the patient had a history of breech delivery, and he actually put the fetal scalp monitor on the baby's butt. We have to know that the baby for sure is head down before we start putting in stuff. So, this is very invasive. You're taking something that was in the outside environment, passing it through the vaginal detritus, next to where there might be a lot of discharge, lochia, blood, possibly feces, amniotic fluid, and you're passing it into the uterus. Can you see how that creates risk? What are we pushing into the uterus with that internal monitoring?
Bacteria.
All of that, right? All of the bacteria, all of the foreign objects, anything that might have been down there on the perineum. So it's really important that we really assess the risks for this before we actually do it. Gives us much better access to the baby, and it's much more accurate, okay? When you talk about the external monitor for the toco, for the pressure, if you take that external paddle, it's just measuring how much the uterus is firming up. But if you take it in your hand and you squeeze it, you're going to see it spike, where it should be recording contractions. Internal monitor is actually by actual millimeters of mercury doctors are much more accurate. We have fewer concerns or issues. Sometimes if we get a really, really fluffy mom, it's really hard to pick up fetal heart rate because there's so much adipose tissue between baby and the monitor. So sometimes doctors will choose that as a reason to do it. Now, FSE, or a fetal scalp electrode, is what we put on the baby's head, is within the scope of practice of nurses within the state of Virginia to place. An IUPC, or an intrauterine pressure catheter, which is what we use for the internal monitoring for contractions, is not within the scope of practice for nurses in the state of Virginia to place. This is a great example of why it's so important that you know what the BON, the Board of Nursing, in your state of practice dictates as within your scope. We had a nurse come from California, started working on the floor. Someone walked in and she was placing an IUPC. She almost lost her job. It's not within her scope to place an IUPC in the state of Virginia, but it is in California. So you will see the nurses placing the FSEs, but you should not be placing IUPCs. If we have a mom who has a significant GBS, we'll talk about GBS strep when we talk about intrapartal. Any kind of significant vaginal infection or heavy bacterial load, HIV, GBS, anything else, should not be placing internal monitors. Kind of makes sense, right? Okay. All right, so let's take a look now that we've got that part out of the way. So the first thing we're going to do is assess the uterine resting tone. What I mean by uterine resting tone, if you take out your strip, there should be a kind of a fairly straightish line between a bunch of hills. There, right here. See it? Yep. So the resting tone is at, yep, that lower space. It should be down around 20-ish between. Uterine resting tone should be down around 20. If we have an external monitor on, it doesn't really matter. It's going to kind of do its own thing. There's a button on the machine where we can zero it out that will bring it back down to around 20. Because we know, again, if it shifts, as baby rolls, if we touch it, it's going to vary. Like I talked about, it's just a little pressure thing. Mom has an internal monitor. If she strays past 20, gets close to 40, we have to worry that her uterus is working too hard and it's going to cause her to get fatigued, uterus to get fatigued, and it's not good for the baby. So for an internal monitor, we really need that uterine resting tone to be down around 20. Any questions? Everybody with me? You see where 20 is on your strip, right? Good? All right, so after we assess the resting tone, we need to figure out the frequency, the duration, and the intensity of the contractions. So, frequency is from the beginning of one contraction to the beginning of the next. So if you look on your strip, beginning of one contraction to the beginning of the next. If you look on your strip, remember those red, darker red lines indicate 1 minute, right? So if you use that, you can kind of use it to help you gauge how long a contraction is. Because if your contraction goes through a red line, you can go 1 minute and all the way to the next one. Okay, there's a second one, up, and about another 30 seconds. So that's like 2 minutes, 30 seconds, right? So it doesn't have to be exact. We're not going to write down that it's 2 minutes, 0.52 seconds. That's not what we're doing. We're giving an approximation. So if you look at your strip, just find where it first starts to go up into a contraction. And then count those boxes to the beginning of the next. Does anybody not have any contractions on their strip? Everybody have some sort of contractions on their strip? Hills on that bottom strip, okay? So from the beginning of one to the beginning of the next, also use your red lines as a minute. So if your contractions are 5 minutes apart, you can just count red lines, right? And then pick up the extra little boxes that might be on either side. Good? Beginning of one contraction to the beginning of the next. Duration of each contraction. From the beginning of one contraction to the end of that same contraction. That's the duration. Makes sense. Most contractions should be between 60 and 120 in order to be efficient. So most contractions are 60 to 120. Again, you should be able to count the boxes to see how long the contractions for your patient are. As a L&D nurse, you have to record every 15 minutes to every hour, depending on what's going on with your patient, all of this. Joy. All right. So, regular old terms, shouldn't be anything of a surprise. The increasing side of the contraction is called the increment. The very top is called the peak of the contraction. The downward slope is called the decrement. Okay? So, you need to know duration, frequency. Now, intensity is something that you'll palpate if your patient is external. Pretty much palpating it either way, actually. So, if you take your finger and you squish your nose, that's a mild contraction. So if you have your hand on your patient's belly when she's having a contraction, and you just kind of very gently give a little squeeze, if it's as soft as your nose, that's a mild contraction. So intensity is mild. If it's as firm as your chin, that's about where we want it. We want it moderate. We like moderate. Okay, moderate is efficient without exhausting mom. So mild, moderate, firm. Intensity is firm or hard or high, depending on who you talk to. Your forehead. Forehead. If mom's belly feels like your forehead when you palpated her contractions, we want to probably do some interventions, which we'll talk about later. Good? Everybody with me? All right, so let's look at these. What is the frequency, duration, intensity of these contractions? Well, I'm going to start right here. Okay, and you can't see the red lines on this, and I do apologize. But we're going to assume that that's a red line right here. So if I look at this, I can go start here. So 10, 20, 30, 40, 50, 60, 70, 80, 90, 100. 100 seconds is actually what? 1 minute 40 seconds. So this contraction lasted for 1 minute 40 seconds. Okay? But then if we're going to look for frequency, we're going to take the two contractions that are closest together and then find two contractions that are the farthest apart. What the nurses are doing this on, depending on what's going on with the patient, they're looking either a 15-minute strip to get those numbers, possibly a 30-minute piece of strip. The patient doesn't have a lot going on, but we're monitoring for some reason anyway. It might be a whole hour. Best way for you to do it on the strips that you were given is to stretch it out until you have a good 15 minutes or so. So if you look at your piece of paper, it's going to be probably about 5-ish squares or so. And again, if anybody is having a hard time seeing what I'm talking about, I've got more contractions up here. Anybody want a different piece? I've got some better contractions. Alright, so if I look at the strip that's up on the board, that first contraction that I just counted, the next contraction is right after it. Those are the two closest together on this. So if I were to count for that entire stretch, and we're going to eyeball this. We're going to eyeball it, because remember we're going from the beginning of one to the beginning of the next, right? So we already know that to here, this was a minute 40. So then 50, 60, oops, a minute and 50, 2 minutes to 10 to 20. So these contractions are 2 minutes and 20 minutes apart. Does everybody see how I got that? Makes sense. Pretty easy stuff, right? All right, so we're going to take the two closest, then we're going to take the two farthest. So we're going to go this one to this one. Now again, we don't have our red lines, so we're going to count really fast. 10, 20, 30, 40, 50, 60, 70, 80, 90, a minute, 90, 10, 20, 30, 40, 50, 60, 1 minute. 10, 20, 30, 40, 50, 60, 2 minutes. 10, 20, 30, 40, 50, 60, 3 minutes. 10, 20, 30, see 4 minutes. So these contractions are approximately 2 to 4 minutes. That's why we're counting between the two closest and the two farthest. You can see how those red lines make such a huge difference, because instead of having to do that, I could have just looked and said, oh, I've got 4 thick red lines, 4 minutes. This is all fairly approximate, okay? Again, we're not charting 2 minutes, 29.2 seconds, all right? 2 to 4 minutes is what we're looking at here for these ones. Everybody with me? Good on contractions? Understand what you're looking at? If you're on L&D, which hopefully all of you will be at some point, you're going to see a great big monitor in a couple different places in the nurse's station. It's going to have a whole bunch of strips like this running for each patient, just like on telemetry. Okay, so you're going to see boxes just covering a screen. That's for each patient in real time. So you'll have an opportunity to look at this, assess it, kind of practice it while you're on the floor with your patients. Okay, and the nurses are really good about walking you through it too. All right, so that's contractions. That's not good. There's a patient sticker.
Yeah, that's right.
Thank you. Don't know how that one happened. All right, so moving on to fetal heart rate. Take a deep breath. Probably not going to get through all of this today, okay? So we'll pick it up next time, but we're going to get through as much as we can. Fetal heart rate. Top lines instead of the bottom lines. Within normal range was what, Scarlett?
110 or 160?
110 to 160 is where your fetal heart rate should be. We want to know if there's any evidence that the baby is either tachycardic or bradycardic. Tachycardic would be what? Over 160. Bradycardic? Under 110. Babies don't give a crap what your parameters are. They could care less. You can have a baby who comes in that stays 110 and looks beautiful the entire time and is born perfectly normal, absolutely zero problems. This is our normal, okay? This is what we want to see, but it doesn't always equate to what the babies are going to show us. But 110 to 160, know it, love it, recall it, it's going to be on a test. This baby is baseline, just like we would with contractions. This baby is, if we look at the average through all of these without, we're going to talk about what this is in a second, all of these places where it's semi-flat, which this one is not, but that's a good thing. So if I look through here, I see this is 120, this is 130, this is 140. I can kind of see they're kind of averaging out right in the middle of that, right? So what do you think that would be? Right, but what number? If this is 130 and this is 140, and they're falling right in the middle of that line of boxes.
135.
135. So this baby's fetal heart rate is 135. Have you found your baby's heart rate on your strip? Look on your strip and see if you can find your baby's heart rate.
If the line keeps cutting out,
Do you need another piece?
I might.
We have a ton. Useless. Did you find your fetal heart rate? Your but go before. You guys can write on these strips, you're taking them home. Yeah, so make all the notes you want to. When you go to pull it up, don't roll it. Go like this. So that when you open it, see how I'm doing? When you go to open it, you can literally just go like this. Alright? So it makes it easier for you. Yes.
If there's 2 lines for the heart rate, that means there's 2 babies?
No, not typically. It might, because we can't have twins. But if you see another line that's lower, down below 100, that's mom. So mom's pulse ox will also pick up on here. So if you have a second, yeah, that's mom. Yep. Sure enough. And you can see how it's kind of gray. Now we will have twins, and with twins, it's going to look like a normal line like you see, and it's going to look like another bold line over top of it. Do you have twins? Oh no, you were writing on it.
Yeah.
Kind of what twins looks like. Can you see it? Yeah. Okay. So yeah, so that's mom's pulse ox. The monitors are going to pick up mom's pulse ox. When you go to take vitals, it's also going to record mom's blood pressure, her MAP, her pulse rate. Okay? So you might be able to see all of that on your strips in the white area between. Do you have a question? You good? Okay. You good?
You said if you had twins, it would be 2 lines?
Yeah.
So is this?
Together. Kind of together. Nope, that's mama. That's
okay.
mama. Yeah, when they're twins, they'll kind of be bouncing around with each other. They'll pretty much be on the same space for the most part. I don't see anybody with twins. Right now, it's usually pretty evident when we have twins. All right. Questions? Good? You're all with me? I know it's been a long day. All right. Baseline of the fetal heart rate. When you're looking at your strip, and we're looking at the baseline, it should not be just a straight baby is 130 constantly without any change. We want what's called variability. The variability tells us how well the baby is oxygenated. Okay? So, we're going to talk about what that looks like here in just 1 second. It's not going to include those periodic changes. So when I just showed you on the thing and I counted between that acceleration in the heart rate, that nice little bump up to like 160, not counting those. We're counting the base. Alright? So that variability can depend on a lot of different things. Is the baby neurologically stable? Quite often if the baby is not neurologically stable, it's due to a lack of oxygenation. Or the baby's already used up all of its fetal oxygen reserves that it has gotten from mama and it's been stored in the placenta or within itself physiologically. Is the baby tolerating labor well? Is the baby able to physiologically compensate? If mom is having a hard time during labor, a lot of these things might be impacted. Okay? So that's why we use the strips to monitor how well the baby is doing. When we start talking about interpartal, which is the labor process, a lot of this will kind of come together for you. Okay? And that's in just a couple of weeks. So, what are we looking like for variability? I've got examples. So, when we classify a baby as having absent variability, this is a medical emergency. If it looks like this, even less variability than this, literally like a straight line, like you took a straight edge and just made a line, okay? That baby is going to have issues or having some oxygenation problems or concerns or something else going on. Minimal variability is less than 5 beats per minute. What do I mean by that? Well, you said the baseline is 135 and the variability only goes down to 130 or only goes up to 140. That's just a change of 5, right? Okay, so less than 5. Moderate, which is what we want to see, is when that variability goes from 6 to 25. So maybe baby is 130, and then baby is 145, and then baby is 128, and then baby is 142. That's moderate variability, 6 to 25. I've got examples coming up, okay? Marked is not good. Marked is almost as bad as absent. Marked, you cannot tell the difference of X cells, D cells, baseline, anything. It literally looks like somebody took a pen and just made a constant squiggle up and down. I've got an example of that. And those are changes greater than 25. So, absent, these are in your book, by the way. Absent is just undetectable change. We can't tell if it's going from 130 to 131 back again. None. Minimal, 5 or less, right? Moderate, you can see how we call the baseline on this baby, again, right around 135. We go up to 140 and we come down to 129. Then we go back up to 140 and we're back down here to 130. Okay? Make sense? Everybody with me? Okay. Marked. See this? Tell me what your baseline is right here. Tell me what your baseline is anywhere. No idea. Anybody would guess? Can't. This is bad. This is a baby who's not doing well. Okay? Everybody with me? things we're looking for when we're looking at that variability that we want to see the baby having are accelerations. You're going to hear it called accels on the floor. If you take a look at your strip, find your baby's baseline. Once you've found the baseline, look through your strip and find a bump. Find a bump, like this. Find a place where it goes from your baseline and increases by at least 15. So if it's at 130, if it goes up to at least 145. Everybody should have something. Hopefully look through your strip. If you don't, let me know. No, please.
I more had a question on if this would be considered marked.
What's that?
I'd have a question on if this would be considered moderate or marked. Because there's several different baselines, I guess you could say.
So we're going to look through the whole strip. So if I were to take an average on this whole strip, right? This baby had a huge acceleration here. So this is not baseline, right? So our baseline, if we go from here back to that end, your baseline is probably right about 155. And if I take this out and come back over here, so this would be baseline down here, and this would be baseline. So.
But then it goes up to here being baseline for a pretty long time.
Right, so if it's here and then it's here, we're going to take the average. So we're still, if you look at this, we're still right around the 150, 155 mark. Came down a little bit here, but then if I take the average over this entire piece of strip for 15 minutes, we're going to be right around 150, 155. This one might be a little bit easier to read. So you can see your baseline is here, and you've got some accelerations like here. All right, so your heart rate should have gone up by 15, and it should also stay up for 15 to count as an acceleration. We call that a 15 by 15. If the baby is the pregnancy is more than 32 weeks, in order for it to count as an acceleration, it must increase by 15 beats per minute, or go from 130 to 145, or whatever your range is, okay? And it must stay up there for 2.5 of those boxes. 1.5 of those boxes, 15 seconds. So is this a true acceleration? Whoop, 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 whoop. Whoop, whoop, whoop. Am I going the wrong way? Is this a true acceleration right here? What's our baseline?
135.
Yep, baseline is just about 135. How long does this last? About 50 seconds. Is that over 15?
Mm-hmm.
Yes. Does it go up greater than 15 beats? It goes up to 160. However, we want 15. So if it's 135, we want it to hit 50 and stay there for at least 15. Does this hit 150 and stay up there for at least 15? Actually, it does. Yes. So it hits 150 about here and then stays there for a good, count this little nubbin right here and this little nubbin right here, almost 30 seconds. Okay? This is an acceleration. This is an acceleration. We can also count it down here this way, but then also here. I can see that it went up more than 15, right? So this is considered to be a true acceleration. So over 32 weeks must be a 15 by 15. Up by 15, over by 15. Under 32 weeks, 10 by 10. Only has to go up by 10, only stays there for 10 seconds. Over 32 weeks, it has to be a 15 by 15. Under 32 weeks, it has to be a 10 by 10 to be considered a true acceleration. There's many different reasons a baby may have accelerations in their heart rate. You don't need to know. If you become an OB nurse, you can know. All right? Not going to get into the minutia quite that deep. We are covering fetal heart monitoring because it is on the NCLEX. You will need to have a base understanding of what we're talking about OB questions pop up all the time, okay? So, that's why we're going over it. Sometimes they're just spontaneous, they just happen. Baby's happy, reactive, bouncing all over. Sometimes they could be episodic or totally random, or sometimes they can happen because mom is having a contraction. Again, nice to know, not need to know. Good? Good. All right. So one of the things that they still do at the hospital, they don't particularly call for it through A1 any longer, but it's still used because they consider it to be a very predictive test. A non-stress test. You'll hear it phrased as an NST. You will see it in the chart stated as an NST. Okay? We put the mom on the monitor for about 20 to 30 minutes on both the toco and the ultrasound. You're never going to see, I shouldn't say never, very rarely you're going to see one place without the other. Unless mom has had a loss, then we aren't going to put on an ultrasound. I just want mom contractions. But anyway, we know that this is a really quick and easy way to assess fetal well-being. Okay, that's why we do an NST. We're actually looking for uroplacental function, making sure the baby, the placenta, and the uterus are functioning properly and the baby is getting enough oxygen. You'll have patients who are high risk who come into the doctor's office and routinely get put on the monitors for an NST. One of the times you do your rotation over at the doctor's office, if you end up with somebody who does OB, you may actually get to help. I know when we had the last group go over there, we had one nurse who was taking a whole bunch of students, and that's all they did all day was just do NSTs all day long. Okay? Put mama on the monitor. We watch the strip and we look for accelerations. We look for variability. We look for uterine activity that would equate to contractions. All right? If it's non-reactive, now, what's reactive? If mom has moderate variability and 3 to 4 accelerations in that 20 to 30 minute period, her NST is considered to be reactive. Okay? We want a reactive NST. A reactive NST is telling us the baby is well oxygenated. So reactive is moderate variability, 3 to 4 accelerations during that period of time. We do NSTs routinely throughout pregnancy if mom has had any other kind of high-risk indication. You'll also see them done when patients come up to triage on L&D. Before they do anything else, they pop mom and baby on the monitor. They're going to look for the baby's reactivity. They're also going to look for uterine contractions. So when you're on the floor, you're going to see monitors a lot. So what does that look like? A reactive NST is going to have accelerations. Contraction activity for that doesn't really matter. We're basically just looking at the baby. The baby has good variability. The baseline is not tachycardic, is not bradycardic, and we've got a couple of accelerations in this very small strip. Good? Reactive NST.
What is the specifications for it to be reactive?
To be reactive, it needs to have pretty much what I just said. So no brady, no tachy. Good variability of the baseline. 3 to 4 accelerations for it to be a reactive NST. Now the parameters have changed in the hospital, especially if the midwives are up on what they're supposed to be doing. We're not necessarily counting accelerations any longer. We're looking for variability and a lack of decelerations. I tell you that because that's what you're going to see possibly for some people on the floor. For testing purposes, we're going to be talking more about classifications of babies, which we're going to talk about eventually. We're not going to talk quite as much about reactive NSTs, but you do need to know what one is. All right? You are going to see them on the floor. You are going to see them talked about. Everybody good? All right, so a non-reactive NST, no real accelerations. We have some decelerations, which we're going to talk about here in 1 second. Now, the baby has some maybe moderate right here, but look at the rest of the variability for this baby. Pretty minimal, right? Not a lot. Now, we kind of go up a little bit here, but we're always looking at the entire strip, whether it be 15 minutes or 30 minutes or an hour. So if we know we're having to chart on a 15-minute piece of strip, we're only talking about the averages that we see during that time span. You can have babies who look great for 15 minutes and then look like awful for 15 minutes and then back to great for 15 minutes. Okay? So you're charting and we're looking at that one piece. You can't stretch out 6 hours and try to chart it because it's going to be all over the place. So non-reactive. Things that cause a non-reactive NST, sometimes the baby's just sleeping. Sometimes it's no more than baby is just in a sleep-wake cycle. Baby's left asleep, they go about 20 minutes off, 20 minutes on, okay, while they're in utero. So if we know that we have a non-reactive NST, we're just gonna keep her on for another 20 minutes. Simple as that. She still remains non-reactive, there's other things we can do. But that's how we treat a non-reactive, we just keep her on, look at her for a little bit longer. Alright, so we talked about accelerations, let's get out decelerations real quick, and then we'll probably call it a day and pick up here soon. I think I have this, pretty sure I have this one recorded as well. I think it might be on the Canvas. Is it already on the Canvas page? Okay, good.
It's not.
But it's not?
No.
Fetal heart rate? Fetal heart monitoring?
Nope.
If it's not, we'll look it up, but I'm pretty sure I have it. It's again from COVID, so don't look at my nasty t-shirt.
Unless it's included in the development lecture.
Oh, it is?
I'm saying unless it is included in the fetal development.
I'll take a look. If it's not there, I'll make sure it's posted and I'll let you guys know. Okay. But we do need to go over this because this is stuff you're gonna have to have. Alright, so deceleration. So if an acceleration is the heart rate increasing, a deceleration would be it decelerating, right? So if we know a baby's heart rate is 135, if it drops down 10 to 15 heartbeats per minute and stays there for at least 15 to 30 seconds, we have a deceleration, depending on the criteria that we're going to talk about in 1 second. What causes the baby's heart rate to decel? Head compression, baby getting squeezed, head getting squeezed specifically. When does that happen? During labor. During labor, yes, and during the actual birthing process. Once the baby's head descends into the pelvis, the baby's going to have a lot of pressure on its head. Once the baby is actually descending out of the pelvis, getting ready to be born, we're going to have even more pressure. This is when we know we're going to see early decelerations. We're going to talk about what that is here in just 1 second. But early decels are caused by head compression. I've got a really good way for you to remember it here in just 1 minute. Uteroplacental insufficiency comes back to what we were talking about a few minutes ago about decreased variability. There's a minimal or absent variability is often caused by an oxygenation issue. Late decels, same thing. Placental insufficiency, not enough oxygen making it to the baby can't recover, okay? And again, this will all make sense in a second. Umbilical cord compression, so the loop of the baby's umbilical cord fell down next to the baby's head, very low in the pelvis, and every time mom has a contraction, it's squeezing the cord against the baby. Head, shoulder, back, some hard place. It's going to cause a variable. All right, what are those easy to remember things that you can do? And I'm going to show you how these all look here in just 1 second. Field chop. This is a really great thing to put on flashcards. Field chop. If it's a variable, it's caused by cord compression, right? If it's an early deceleration, it's caused by head compression. An acceleration is okay, you're O and chop. A late deceleration, placental insufficiency. Feel, chop. Know it, memorize it, love it, remember it for the NCLEX. Okay? Got it? Good? Alright, so what are we talking about when we say early, late, etc., etc.? An early deceleration is going to occur with contraction. The baby's heart rate is going to decel with the contraction and come back up to baseline by the end of the contraction. It also looks like this. Do you see how it mirrors? Early decelerations mirror the contraction. Remember, they're caused by fetal head compression. So if you critically think about this, if we know it's caused by head compression and they mirror mom having a contraction, well, of course, right? So early is head compression lines up with the contraction, okay? A late deceleration,
Bless you.
actually I went to variable first. A variable caused by placenta cord compression. Variables are gonna look like a V. This isn't really a good representation. This is. Variables can happen at any time. They don't necessarily happen with a contraction. They can come whenever. And remember V for variable. Veal chop. V for variable. If it looks like a V and it's greater than 15, it's a variable. You can't count those little jaggy variability in the heart rate as an actual variable. It has to be at least 15, if not more, be very distinct. Quite often these go really deep. So let's take a look and see what that looks like. One more. This is a good example of a variable. Now, 30 at the very, very bottom, less than 30 seconds at the very bottom is usually the criteria. Then it goes down in less than 30 seconds, it's less than 30 seconds at the base, and then less than 30 seconds to come back up. I would argue that that's on the borderline of being an early, okay? They typically will look more like a V, like the one on the very end. So you see it drops very, very quickly, stays down for a brief period of time, and it comes up pretty quickly. Make sense? All right, so V, variable. A late deceleration. Unlike the other two, late deceleration are going to be, well, not like the other two. A late deceleration is going to start to decline at the peak. So you'll see the nurses on the floor going up to their strips or at their computers. If you go up and you take a pen, you put it at the peak of that contraction, and you see when it starts to decline, you see that it actually, the heart rate starts to decline at the peak of the contraction. It doesn't return to baseline until after the contraction is complete, and then it slowly starts to come back up. What is a late deceleration caused by?
Placental insufficiency.
Placental insufficiency basically means a lack of oxygen, okay? So that's what, these are not the best, but if you go up here, right? If I come up and I draw a straight line, you can see it starts to decline. It gets to about 15 below what baseline was, and then it comes back up. That's kind of a subtle late. Starts to drop, comes back up after the end of the contraction. These are not the best examples. There's more in your book, okay? Variables we already talked about. This is a prolonged deceleration. Anything over 120 seconds or 2 minutes is considered to be a prolonged deceleration. This would probably end this baby back up in a C-section one way or another, especially if it happened again. So baby's heart rate dropped significantly, came back up. This is what contractions are gonna look like when mom is pushing. They look like Bart Simpson heads, right? They look like Bart Simpson. With every push mom gives, the pressure on that toco goes up, right? So she's gonna have a nice flat area, and then she's gonna take a breath, and it's gonna come back down. And she's gonna push, and then it's gonna come back down, okay? So if you see this on the floor, that means that mom is pushing. When we come back again, we're gonna run through the categories. This is one of the most important parts. There's only about 15 slides left, so we'll go through all the categories. I do want you to look at the video. I'm gonna post it. One thing I wanna show you really quick, which is really good practice, and I highly recommend you to take a look. You go down into Unit 2, you're gonna see this EFM game. And no, I do not see the categories, because it's gonna be a little bit different than what you think it might be. you'll see that under EFM, there's now one that says EFM resource. So if you don't really want to play the game, this one is more of a it's not really interactive as much, to kind of walk you through, and it's what they typically use to teach the docs. It's actually an OB one. So if you're having difficulty understanding it, it kind of takes it from a different point of view. It might help you if the EFM game wasn't something that was really to your fancy. Might be a little bit easier to follow. Just to make sure that you do. Decels, weights, variables. How do you know it's a variable? What's it look like? Looks like a B, right? Looks like a B. Alright, so this is where we stopped talking about the categories. So when we're on the floor, pull out your strips, take a look, have them out so you can kind of compare. We look at categories. We're going to have 3 different categories. We're going to go into depth talking about them. This is what you're going to really need to know. Because when you're on the floor, the nurses may come up and say, hey, look at that strip, what category do you think it is? And you're going to need to be able to say, oh, I think it's category 1, I think it's category 2. It's kind of how they monitor it on the floor. Okay? So if you are down in the ED and somebody comes in and they put them on the monitor, you could be that special person that says, oh, no, that's a category 2. We have to do A, B, and C. Category 1. Category 1 is normal. Category 1 normal means that we have adequate variability. What would be adequate, what do you think, after our discussions last time we met? What would be adequate variability? What do you think?
Is it a change of the fetal heart rate that's at least 15 beats over, is it like 15 seconds?
So those would be accelerations, right? So accelerations are definitely a good predictor of a category 1 strip. But we're looking, a lot of it, we're looking at variability. So besides accelerations, what do we mean by variability? Outside of accelerations or decelerations. Do you remember what that number range was? Because you're going to need to know.
6
It's
to
moderate
25.
variability. What's that?
6 to 25.
Yes. Good. And that would be considered to be what kind of variability? Remember?
Moderate.
Moderate. Pull out your notes, didn't you? Probably a good idea for everybody to pull out your notes and take a look. We talked about stuff you went over last time. Moderate variability, or beats that change from 6 to 15 in between, is considered to be moderate. So, moderate variability, possible accelerations, but the big thing is we don't have any decelerations, and the baby is not Brady or tacky. Okay? So if the baby's not Brady or tacky, where do we know that heart rate to be? You can find this out on your strip. Where's that highlighted area on your strip for the baby? These ones don't have it, it's on the computer. 110 to 160. 110 to 160 would be considered to be within the normal range. Anything less is Brady, anything higher is tacky. So we have a baby who's not Brady, who's not tacky, who has good variability, moderate variability, and has accelerations. Okay? That is a category 1. So that means a category 1 is, what do you think? Good, bad, indifferent? Good. We want to see babies at a category 1. Okay? That tells us we have a baby who's doing good. We know that this baby has probably got great oxygenation, which means the baby also has a normal acid-base balance or status. What changes our acid-base balance in our bodies as every single kind of mammal? Breathing. What happens if we're not breathing well? You become acidotic. So when we say that we know this baby has got a normal acid-base balance, that means we know the baby's being well oxygenated. Make sense? Alright, category 1. Category 2. Category 2 is indeterminate. Category 2 means that we don't know what we're looking at quite yet. Now remember, we talked about the nurses on the floor, quite often, depending on what's going on with the patient, have to be charting every 15-ish minutes. Well, babies go through sleep-wake cycles, sleeping for 20-ish minutes, being awake for 20-ish, 30-ish minutes, and then going back to sleep again. So if we have a baby who's in a sleep cycle, and we're looking at their strip, and less than 5, right? So if you have a baby who's minimal variability, maybe a possible variable every once in a while, possibly an occasional late decel, but literally even doesn't have decent variability, we're not seeing any accelerations. Well, that also describes a baby who's sleeping. So can we describe a baby's acid-base balance on a 15-minute piece of strip? No. Can you assess any of your patients based on over a 12-hour shift over a 15-minute window? Because your patient comes back from surgery, they look the same right after surgery as they are 6 hours later? Probably not. So while we need to chart it where the baby is at that time, and we may very well be charting that as a category 2, over the course of the day, if we were to go back and look, we would hope that we would see the baby being mostly a category 1. Okay? Now, most strips in L&D, a lot of the strips, are going to fall into category 2 or being indeterminate. This is because those babies quite often are suffering the side effects of inductions, of just being born, of being tired, of being full of medications from mom, or just simply being squeezed every 2 to 3 minutes while mom's contracting, and it can be stressful. So most babies on L&D are going to be category 2s. We hope when the moms come in over the course of their pregnancy to get NSTs done that they're going to be category 1s when we see them at the doctor's office. If we're not, we're going to give mom something sugary or some orange juice or something to hopefully maybe wake that baby up a little bit, make it look like a category 1, get them rolling. We saw NSTs at the doctor's office, and several of you have been so far. Did you see that? Did they have to give anybody anything?
Not mine.
No? No NST bouncing off the walls already? Not any problems? So that's a nice thing too, is the baby, if mom is kind of feeling a little bit nervous because she's at the doctor's office, the baby's having to put on the monitor, that adrenaline's going to go to the baby too and make the baby bounce off the walls. So that's going to kind of wake up the baby a little bit too. So they often, quite often, in the office here quite often have that. So what do we do for a category 2? Well, we need to continue to survey, and we also need to, like I said, take into account what's going on. Do we just push 5 milligrams of IV morphine? Is mom on medication because of a pre-existing condition that's causing the baby to be sleepy, is causing mom to be sleepy, such as magnesium sulfate, which we'll talk about later? We have to look at the clinical circumstances going on. So category 2, we are going to go in and do some interventions, some intrauterine interventions, which we'll talk about here in just 1 second. But those interventions are something that we have to do for a category 3. So if a category 1 is normal, and a category 2 is indeterminate, meaning that we can't decide just from what we're looking at if this baby is good or not good, then a category 3 is abnormal. These babies are usually not good. They quite often have an abnormal fetal acid-base status. They're probably holding on to too much CO2. Rarely do we give them too much oxygen. This is going to require prompt evaluation. We're going to go over the 4th bullet and what that requires here in just a second. We know that if this isn't immediately addressed and corrected by the interventions that we're going to do, that the baby could suffer from possible acidemia. Not okay. If the baby is actually showing acute signs of acid-base concern, that baby's going to be a SAC section. So category 3, if we cannot get it corrected, that baby's coming out one way or the other. Okay? This could mean absent variability. What do we mean by absent?
0.
0. So no variability, that straight line, right? This could also mean a baby who is severely Brady, or is having recurrent over and over and over and over again. Late or variable decels, especially those that are really, really deep. Okay? This could also mean a sinusoidal pattern. Anybody remember from your math classes what a sinus rhythm is or a sinusoidal pattern is? That is sinusoidal. So if your baby strip looks like this baby's in trouble. But Mrs. Hobbs, it looks like great variability. No, it doesn't. It looks like a baby's cardiac rhythm is struggling to maintain, and this is all we can come up with. Sinusoidal is very bad. Marked. Also very bad, right? Remember we talked about marked last time? So just a little tidbit. You may also end up seeing on the TOCO, when we are monitoring uterine activity, that indicates an abruption. The uterus is literally sitting there just doing this. Can't quite calm down. There's something going on. The uterus is just gonna sit in there and quiver, and it's gonna come across the screen looking like that. Something that most women just don't get until they see it, and then they freak out. All right, so what do we need to do for this? We're gonna call it the Big Five, and it should be in some semblance in your notes. Do you have the Big Five written down someplace in there? Really? You don't? Not at all. All right, so the first thing that we do is we move mom. Patient positioning. What side do we put patients on to promote the best circulation?
Left lateral.
Left lat. We put mom left lat. If that doesn't correct the baby, we are gonna go ahead and roll her to the right, but we're gonna start with the left. Unless at some point or another mom's already rolled on her left and we've seen baby crash even harder.
Does the categories go into the charting, or is it just like
It's part of the charting.
Okay.
It's part of the charting in Epic. It'll be, and the computer I think actually does it now for the nurses based on the information they put in. So we're gonna turn mom on her side. Still doesn't get better. Still not doing great. Well, next thing we're gonna do is we're gonna give her an IV bolus. And you see that? We have a patient who got just pounded full of fluid when we were there. Who was it that ended up getting like 5 bags over the course of who had the bad epidural? Patient kept crashing. Was that yours? That was yours. No, I'm looking at Kelly. She ended up getting how many bags? It was a lot.
It was really only like 2, maybe.
2 bags? 2 liters?
Mhm.
I think she had some more before we got there though. I think there was some, I think that they were having a hard time maintaining the blood pressure all the way around. One of the things that we do to correct hypotension in moms is to give them a bolus of fluids. We tend to do this before they get their epidurals to make sure they don't become hypotensive. A hypotensive mom makes a hypotensive baby, which makes the baby crash, which makes the baby go into a category 3. So if we give mom fluid, quite often, not always, but quite often that can correct some of the hypotension for both mom and baby by upping mom's blood pressure with extra fluid in her system. However, what happens if we continually are pouring fluid into mom? Where's that fluid gonna go? That and
To baby.
lungs. You're gonna end up with a mom who's got pulmonary edema. And when you take over for a nurse coming off the floor and walk into the patient's room and see she's foaming at the mouth, it's not fun. Especially when she ends up in ICU for 3 days. Been there, done that. Not okay. So while giving them a bolus is a great way to increase her blood pressure, we have to kind of take note of what we're pouring in. And up until recently, they did not do eyes and O's. People would literally go in and just off of the pump, would just go in and crank open the fluid and just let it pour. And you'd walk in and you had a mom who had 4 or 5 liters over the course of the previous shift. And nobody was reporting it. Not okay, right? So we have to be very careful when we talk about increasing fluids. So if giving her a bolus and turning her position doesn't change it, and if she's on some kind of medication to induce labor, such as Pitocin or oxytocin, we then have to turn off the induction or augmentation. So turn off her pit. Position change, fluid bolus, turn off the pit. Because 99% of the patients up there are probably going to be on there. Turn it off. Oxytocin, excuse me. Pitocin, oxytocin. None of this has worked. Your baby's still crashing. You've got a baby who's in the 60s. They've been there for 3 or 4 minutes. You have flipped her from side to side. You have turned off her pit. You have given her a liter of fluid. What do you think your last intervention is?
Oxygen, call the doctor.
Good job. Did you read ahead? You're going to put her on O2. Give her some O2. Maybe we can force some O2 into the baby. And by the time you get to the point where you're putting O2 on that patient, and yes, it is a part of your PRN orders, you can just do it. By the time you get to the point where you're putting on that mask and cranking it up to 10 liters, you should have already been calling your doctor. So calling your doctor is the 5th intervention. Calling the physician to get in at the bedside. Category 3 can oftentimes indicate that we've got a really, really bad situation. However, category 3 can also just say that we have a baby who's hypotensive and they come out screaming and yelling back in the OR with F-4s of 9 and 9. So we don't know what we don't know. And I'm not a fan, and we know that EFM is not necessarily the most accurate thing that we can be doing for our mamas and our babies. But I will tell you a story. We had a patient come in, Langley. The wife was in labor. She was doing really well. It was, I think their second or third. They'd already had one baby. Well, they had one. It was their second. Their second baby. She came in. She was doing beautiful. She came the night before. She was getting an induction done with a cooked balloon, which you'll see if you haven't seen already on the floor. And I also have one in a kit of stuff that I keep meaning to bring over. What's that? Oh, it's horrible. It's torture. But she was being induced. Put her on pit in the morning. Baby looked great. Baby was category 1, category 2, minimally, category 1 mostly. Mom was sleeping. Everything was fine. And about 2 hours into our shift, I was charged, so I didn't have a patient directly. But about 2 hours into the shift, the baby's heart rate plunges into the 60s, and in the 60s, and in the 60s, and minimal variability, and in the 60s, and there was nothing we could do. We were flipping and flopping and fluids, and we even gave mom some epi, and mom did not have an epidural, and there was just anything we could do, and the baby was solid in the 60s, would not come up. When the mom came in, we, of course, had all of our labs and everything, and the baby, or mom, was GBS negative, didn't test positive for anything, no complications. We went back to the OR. From the time the baby dropped to the 60s until the baby was taken via C-section was like 7.5 minutes. We only stared at the baby in the 60s for about 2 or 3 minutes. And obviously it was something catastrophic was happening, so we knew we had to get the baby out. So anyways, we take the baby out, and you will never ever tell a patient that everything will be okay. As soon as you do tell a patient that everything will be okay, and have it come back and bite you in the ass. And I walked out of that room, as charged, I should have known better, right? And said, no worries, Dad. Mom will be done, half an hour. We'll have the baby back to you in the room in just a few minutes. The baby was dead. The heart rate that we were seeing was mom's. The baby was not compatible with life. At some point or another, a GBS bacterium had gotten into the baby's system and populated the entire thoracic cavity. When they went to intubate the baby, they could not get return. There was no chest rise, there was no return, there was nothing else. Couldn't figure out what they were doing. Kept thinking they were in the stomach. Nope, not in the stomach. They worked on that baby for over half an hour. Baby went out for autopsy. The baby's entire thoracic cavity was full of group beta strep. There was so much pus in the baby's chest that it had expanded as far as it could possibly expand. There was no way the baby would have survived no matter what. Wouldn't have mattered when they took the baby during the course of the half a day that we had the mom. Baby was already gone. So we don't know why the baby appeared normal for the first 12, 13 hours. Unless it was just to the point where we were at that point in the delivery process where the baby was having to rely more heavily on the placenta that did not have the stores that were needed to maintain even brainstem function. So the baby was brought back to the room before mom in a swaddle and gone. Don't ever tell your patients everything's okay. Ever. Ever. I don't care if it's a toenail removal. You never say to your patient, everything will be okay. The baby had a category 3 after having a beautiful strip all night, and then the baby was dead. So, we know that it does indicate problems. We also know that sometimes we miscalculate, misassign too. So, those 5 things, that is your intrauterine resuscitation. You need to know all 5. You need to know all 5. And you need to know them in order. Okay?
I think I missed one. So I've got patient positioning, IV bolus, turn off pit,
when you feel that you're at the point where you need to be putting O2 on that patient, you need to call the doc. Questions? We good? Alright, so to give a little bit of a summary of electronic fetal monitoring. First thing you do is you determine your uterine resting tone. Look at your strips. Pull out your strips, take a look. Where should your uterine resting tone be? Not saying it is on all the strips, but where should it be? Remember? Where do we want it? Yes, right around 20, right? So you want uterine resting tone right around 20. Remember that the TOCO, when it's an external monitoring, that it's going to adjust itself as needed, but we do want to see it right around 20. And what about your contractions? Remember that when we're assessing uterine activity, we need to make sure we're assessing frequency, duration, and intensity. What is frequency? How do you define it?
One contraction to the next.
Beginning of one to the beginning of the next, right? How do we define duration?
Seconds.
How long each contraction lasts, right? Makes sense. Duration. And then how do we determine intensity? Poke our eye out.
Palpate.
Yeah. By palpation, unless we have somebody on an internal monitor, then the internal monitor will tell us. We're going to talk a little bit about that. So we want to assess frequency, duration, and intensity. And then for the fetal heart rate, we need to determine again our baseline fetal heart rate. Where is your baby's baseline fetal heart rate if you look at your strip? Can you tell? Do you know? Yep, yep, absolutely. But the whole thing. You've got twins. Who was asking about twins? We've got a twins over here. So baby A, your darker line, yep, right around 120, and then baby B, I would say more around 125, 130. But look like a chunk, right? So we always want to make sure we look at a chunk. So I see like here, 125, 130, I would say. And then remember the paler line underneath, way underneath, is mom's heart rate if she had a pulse ox on, right? Did you ball that up for the mirror? Man, after last night?
Yeah. Slipped down there.
So you are, right? So probably around 125. Look at your strip and literally tell that it's actual millimeters per mercury. Can you see it?
Yeah, I was surprised. I saw these numbers, so I was like.
Oh, gotcha.
Thank you.
When we're talking about external monitoring, it's going to be a little bit harder to judge. We're going to pretty much be zeroing around the machine. That's your baseline that you want to see. So remember that 20, okay? Everybody good? Everybody find a baseline? Good? Sorry, thanks. That's okay. So, maternal baseline, so here's 120, right? It's kind of bounced around up above that 120. So if I were to look down here, especially where it's continuous, usually your baby was kind of sleepy, and then all of a sudden we got great moderate variability. Look, you even have a good ASL right here. So this is sleeping, this is waking, and this baby's probably right around I would say 120, 125. Because look, we're right around 120, then we're up here around 30, and then 125. Yeah, I'd probably call that one around 125. 120, 130, 125, 130. Because if you kind of go bounce, see down here all the way down to 120, and then 120. Yeah, I think probably 125-ish. Got it? Good?
Yeah.
So, yeah, very happy baby. Been told, said, give me all of these things, right? You're going to need to know what your normals are. Okay? We're tracing mom. We're tracing mom. That is all mom. Okay. Is what that is. Yeah, no. So what probably happens, she probably got a epidural. There's baby all broken up. if we have, what?
No, how many accelerations?
4 and 20 minutes for an NST.
Thank you.
But we're moving away from NSTs. We should be, according to A1. A lot of doctor's offices in the hospital are still using it. But we should be moving more into categories. So if we have a baby who has a reactive NST, moderate variability, accelerations, no decels, no variables, we already know the baby is a category
1.
1. No Brady, no tachy. Moderate variability, with or without accelerations, no decels, 1. Okay? Which also describes an NST. Okay? So, you've got your fetal heart rate, you've got baseline, you've got your variability, minimal, moderate, then you need to determine if you have any accelerations or any decelerations. Did anybody have any good examples? A deceleration or an acceleration on your strips? Do you know what they look like? When do we cut off 15 by 15s? When does it have to be less than that?
Less than 32 weeks.
32 weeks and below, 10 by 10, right? Over 32 weeks, they have to be a 15 by 15 in order to be an acceleration. And what do we mean by 15 by 15?
3 blocks.
3 blocks. Well, that's 30, but, right? 2.5. 15 by 15, 15 seconds long, by an increase of 15 from the fetal heart rate baseline. So if I have a patient, or a baby, whose baseline is 140, baby needs to get to 165 and stay there for 15 seconds in order for it to be considered to be an acceleration. Good? Everybody with me? Alright, so that's EFM. Play the game, do the things, read your notes, do the other thing that I put up. You're going to be given a scenario, and it's going to say you were taking care of a patient in labor. This is what you're seeing on a strip. This is what's going on with mom. What do you do next? Okay? This is not going to be, what's normal blood pressure? We're not doing those questions anymore. Alright? These are going to be, you have to know this information and apply it to your patient at a point in time. Okay? Not saying there aren't some knowledge questions, but there's also going to be a lot of, this is what you got, what do you do? Yeah.
So if a mom is given Pitocin, would that mean that her uterine contraction would be greater than 20? Or if we're thinking, I guess, to send them into labor, it would go to 20?
So baseline should be 20 or less, because that shows us that the uterus is completely resting, and she has an internal monitor.
Okay.
So less than 20 millimeters of mercury, or degrees of pressure that the uterus is putting out, tells us that the uterus is just like my arm, my muscles are just relaxed, right? So when she starts to have a contraction, we expect to see that, and we're not going to get into it because it's very, very specific and in-depth, and you don't need it unless you're going to be an OB nurse, but it's called Montevideo units. We're not going into MDUs, but we actually have to calculate how much pressure by how big the contractions are. So when we talk about intensity, whole different thing. You don't need to know that for this class. You don't need to know it for the end class. However, we want resting starting at 20, and it can go up as high as it wants to if it's external. Because then what happens if you go in and you've got somebody who weighs 280 with a monitor on, and there's 3 inches of adipose tissue that the monitor's trying to, right? Or you go into a room and the patient's 110 soaking wet, and she looks like she has a basketball on her belly, and there's just skin between. Right? So it's going to vary by positioning, by infant movement, and by mom's physique.
Okay.
Okay? So what you're really looking for is this, you want to be able to know where that rolling hill is. How do you count your duration? How do you count your intervals?
Okay.
Okay? Frequency, I should say. Good? Any other questions? Alright, so the other type of auscultation that we can do, or I'm sorry, the other type of listening we can do is intermittent auscultation. If you remember that when we first started the lecture, 2 weeks ago, we talked about the stethoscope, which is this lovely thing right here. You'll still see a lot of midwives using them in the field. Older midwives. Typically now they use a handheld Doppler. A handheld Doppler and a stethoscope do the same thing. They provide us an easy, non-invasive, non-strapping mom to a bedway to monitor the baby. A1 recommends intermittent intermittent auscultation for all normal pregnancies. If mom is not being induced, she doesn't have a comorbidity that requires medication that could make things bad, such as hypertension, multiples, things that make it a high-risk pregnancy. She doesn't require any of the special stuff. If it's not labeled high risk, there's no reason we can't do intermittent. Intermittent auscultation, it varies by policy depending on what hospital you're in. It really is reliant on the provider, although typically, when we do intermittent auscultation with a Doppler, we go in, we put a hand on the belly so we can know when a contraction's coming, and we listen to the entire contraction. And then we listen again between the contractions and then one more contraction, and we say, okay, we're good. And we take note of any decreases in the heart rate. That's why it's so much easier to have a Doppler so you don't have to count in your head. Take a note on the Doppler readout screen. Did the baby's heart rate go up, down, stay steady? What was her baseline for a contraction and at rest? And we typically do that once an hour instead of strapping her to a bed with straps. So intermittent auscultation is actually the recommended practice for all normal pregnancies. We're getting a little bit better about it at regional, not the best. When it was introduced in the 1960s, very few people actually, when electronic fetal monitoring was introduced in the 1960s, very few people actually used it. It was understood that it was only for high-risk deliveries. However, by 2013, 89% of all patients that have babies in the hospital were being strapped down to the bed and used with continual or with straps. Why is this a problem? What can you not do when you are told you have 4 feet of wire and that's as far as you can move from your bed? What can you not do? Ambulate. What do we know that ambulation does for deliveries? Gets it out, right? So if you have a mom who looks like the top picture versus the bottom picture, who in that picture is more at risk for ending up back in the back for a C-section? The top. Why? Can she freely move around? No. Can she get up from the bed? Can she go to the bathroom without having to ask somebody? No. Is she able to listen to her body? Can she get on her hands and knees? Probably not any of the things that are above. We should not be putting patients on monitors who are not high risk or have some kind of medication like Pitocin or magnesium running. We know that those who are listened to via IA have a lower rate of surgical vaginal births and C-sections because they can get up and move and get the baby out the way it works. It's also very empowering because what else have you done besides kind of tie her to the bed? Does this look like a non-medical procedure? It's like a pretty medical procedure here, doesn't it? She looks like she's undergoing some major significant mental involvement. Birth is not a medical procedure. It's a normal physiological event and we're just taking it away. Versus the mom on the bottom with a midwife who's using intermittent auscultation, who's sitting in a pool, by the way, in her living room, who can freely get in and out of that pool, go take a shower, lay on her bed, go have some lunch. Non-medical, medical. When we make a procedure that's supposed to be physiological, a medical procedure, we end up with C-sections, surgical births. We know that there is zero difference in outcome. There is zero difference in fetal outcome. Electronic fetal monitoring has done nothing but increase our C-section rate. If you don't believe me, look it up. Literally, the only thing we have done by continually monitoring our patients is increase their C-section rate. Now there's anomalies, like the story that I told you. That baby was gone. It wouldn't have mattered how we were monitoring the baby. The baby was already gone. We would have caught it with IA as well, but not instantaneously. However, again, there's no difference. No special equipment, see the Doppler, it's not invasive, doesn't have to be strapped down to the bed. Alright, so when should we be choosing electronic fetal monitoring? Like I mentioned, talked about, that mom's gonna be on continual monitoring, even though we know that was a freaky, weird, God only knows. Meconium, when the baby has a bowel movement in utero, right? GDM, gestational diabetes, multiples. All of those conditions are considered to be high risk. All of those conditions require mom to be continually monitored. And in those high risk situations, we know that we do have better outcomes for mom and baby. In a normal delivery, a normal pregnancy, there is no difference. Okay? Should only be used for high risk. We know that we also have to keep those moms on continual monitoring after they get an epidural, or if we give them IV pain meds like fentanyl or morphine, because those can make the baby crash too. So we need to make sure we're watching. And then also after Pitocin, when we administer oxytocin, we need to make sure that we are. Sometimes it varies by facility policy. Why full-term loss? Are we really worried that she's going to have another freaky accident where the baby might die again in delivery? Why would we have somebody on continual monitoring for full-term loss?
Maternal reassurance.
Maternal reassurance. That's really the only reason. Alright, so woman had just arrived at the labor and delivery suite. Before reporting the patient's arrival to her healthcare practitioner, which of the following assessments should the nurse perform? Just got there. What do you think?
All of them.
What's that?
All of them?
No.
Vital signs for sure.
Vital signs for sure.
Fetal heart rate.
Fetal heart rate. Contraction pattern. Think about what we just talked about, right? It's all about EFM. Good guess. Patient is in the second stage of labor. She falls asleep immediately after a contraction. Which of the following actions should the nurse perform at this time? Two. Leave her alone. She's just sleeping. Nurse also takes a fetal heart rate of 150 beats per minute on a patient in early labor. Which of the following actions by the nurse is appropriate? One. That's within normal, right? Almost 110 to 160? Totally normal. While evaluating the fetal heart rate, monitor tracing on a patient in labor, the nurse knows that there is a deceleration present. There are decelerations present, excuse me. Which of the following assessments must the nurse make at this time? What do we need to know?
One.
One. When are they happening? Because remember, how do we define earlies and lates and decelerations with decelerations, right? Earlies line up with the contraction, lates occur after. Okay? So we need to figure out if it's one or the other. Make sense? Any questions? Yeah.
How do you monitor multiple sections or triplets?
Who had the multiple strip? So they're actually both put on the monitor at the same time, and they come off of the strip looking like this. You see how we have two lines? If anybody wants to see, it's over here. Take a quick break. We got 5 minutes. We're going to come back and go briefly over into pelvic fetal, and then we're going to go into your activity that you should all be prepared for because you watched all the videos. Grab a piece of